If you clicked on this video, then you're probably somebody who suffers from headaches. I have seen thousands of patients with headaches. I routinely see patients who have already been seen by several other doctors for their headaches, but they are still having headaches despite all the treatments. And what I've noticed is that there's a lot of misconceptions that the other providers have, which unfortunately are leading to the misdiagnosis in the first place. And so no wonder that the patients are still having headaches despite years of treatment, because they're getting treatment for the wrong thing. Okay, so let's get started. Within primary headaches, 99% of those headaches are due to either migraine, tension headaches, or what we call trigeminal autonomic cephalalgias. A common example of that is cluster headaches. We'll talk about that in more detail. All right, so let's kick off the conversation by talking about one of the most common headache disorders, which you either have or you know somebody who does, and that is migraines. So migraines, they're about 3 times more common in women than in men. There is a large hormonal influence. So estrogen plays a big role in migraines. And basically, migraines tend to happen usually on one side of the head. However, it could be both. And they tend to have a throbbing, pulsating quality to them. They are often associated with sensitivity to light, sound, smells, nausea, vomiting, and sometimes dizziness or vertigo. There's 2 different ways to classify migraines. One way is basically to classify them with respect to whether or not they have an aura associated with them. So 1/3 of patients with migraine will have a migraine with aura, and the remaining 2/3 will have a migraine without an aura. Now, what is an aura? Essentially, an aura is a sensory phenomenon that precedes the headache. Most often, it's a visual phenomenon like zigzag lines or flashing lights, but it could also be a sensory phenomenon like numbness or tingling or even weakness that can precede the headache, usually by a few minutes to an hour before the onset of the headache itself. And the other way to classify migraines is whether they are episodic or chronic. Chronic migraine means that you're having more than 15 days of headache per month. And episodic migraine means that you are having less than 15. And that has impact on treatment, as I will discuss in a little bit. Common migraine triggers will include stress, sleep problems, hormonal changes, so menstruation in females, weather changes, fasting or not eating, alcohol, especially red wine, food items like cheese, dark chocolate, caffeine for some people, although caffeine can be tricky because caffeine withdrawal itself can lead to a headache. I made a separate video on migraine triggers that you can check out if you're interested. Now, the duration of a migraine can be anywhere between 4 hours to several days. If it's more than 3 days, we call that status migrainosus, which just essentially means a bad migraine. The chronicity of a migraine goes like this. You have what we call the prodrome phase, which is marked by fatigue, sensitivity to light and sound, irritability as well. And then that is followed by the aura phase for patients who are going to have an aura. Like I discussed before, aura is usually visual, but it could also be other sensory modalities. And then after the aura phase is when you have the actual headache phase. And finally, after the headache phase is when you have the postdrome phase. And that is usually fatigue, irritability, changes in mood that can happen after the migraine is over. So during the postdrome phase, patients usually feel exhausted and drained, and that can last for a few hours to a few days. In a nutshell, the treatment for migraines is made of 2 parts. You have what we call the acute treatment, and then you have the preventative treatment. So acute treatment, which is also known as rescue treatment, essentially is when you have a bad headache, how do you get rid of it? How do you stop it? The classic medications used for this used to be triptans, which basically lead to vasoconstriction in the blood vessels. And common examples of that are sumatriptan or Imitrex, but there's other triptans in the family. And those are good medications. However, the caveat is that they have to be taken at the very beginning of the headache. Otherwise, they don't work, because by that time, the blood vessels have already flushed all the inflammatory mediators. So even if you tighten them, it's kind of too late. The other caveat is that because they lead to vasoconstriction, they cannot be used by patients who have had a history of a recent stroke or a heart attack. Other rescue medications can be over-the-counter, like NSAIDs and Tylenol. However, the more recent advances that we have had in migraine have really brought to us a new class of medications that we call the CGRP medications, also known as the gepants. And those gepants, essentially like ubrelvy and nurtec, are excellent medications for rescue. They tend to be safer and better tolerated than the triptans, They don't have to be taken at the beginning of the migraine. They can be taken at any time during the migraine. And they are either as effective or potentially even more effective than the triptans. Okay, so that's for rescue. Now, for patients who have chronic migraine, ideally you want to have a preventative option so that you can prevent headaches from happening in the first place. And preventative options classically used to be tricyclic antidepressants like amitriptyline or blood pressure medications like propranolol back in the day. However, now that we have the CGRP medications, this has really changed the field. And over the past 5 years, we have had excellent new options like nurtec, which can be used for prevention as well. You have qulipta, which is another CGRP medication. You have more injectable options like Aimovig. But then one of my favorite options for migraine prophylaxis is actually Botox injections. And the idea behind that is that we inject Botox in specific muscles of the head and neck, and that decreases the tugging on the nerves that is happening. Botox is one of the best options for migraine prevention. And per the landmark study on this, called the preempt study, there was a 60% decrease in headache frequency, duration, and intensity at the 6 months mark. So that's just after 2 cycles of Botox. But again, remember, this is for chronic migraine. So for people who are having more than 15 days of headache per month. All right, so that was it with respect to migraines. And now we're going to move on to the second category of primary headaches, and that is tension headaches. Now, as a disclaimer, I'm going to say that I'm not a fan of the word tension headaches. I made a separate video on this where basically I'm sharing my opinion that I think that tension headache a lot of times is a misdiagnosis. And in my experience, a lot of patients who are labeled as tension headaches are cervicogenic headaches coming from the neck. And the remaining patients who are labeled as tension headaches are actually migraine patients. So I'm not a big fan of that tension headache label. So I'm going to use it interchangeably with cervicogenic headaches. And the idea behind it is that depending on the cause, which a lot of times could be as simple as stress, a lot of times people carry stress around their shoulder muscles and their traps and their neck. And basically when that happens, or because of ergonomics, or if somebody has had a history of a concussion or whiplash in the past, or even neck surgery, any of those will lead to spasm and stiffening of the muscles of the neck. And when that happens over time, that will lead to irritation of the nerve that you see in yellow right here called the occipital nerve that's trying to pass in between those muscles. And that's what leads to a lot of those headaches. Now, that nerve has more than one branch. You have the greater occipital nerve that you see in yellow right here, and that one goes from the back of the head all the way here, and then it leads to also deferred pain behind the eyes, what we call retroorbital pain. And then you also have the lesser occipital nerve, which goes more toward the temple and the ear. So people can get temple pain from that as well. Tension headaches or cervicogenic headaches tend to be on both sides, but they could sometimes be only on one side. They tend to affect the occipital part of the head as well as the frontal part sometimes, retroorbital space, so behind the eyes, the temples. So unlike migraines, which we said were throbbing and pulsating, cervicogenic and tension headaches tend to be more of a dull ache, more of a pressure sensation like a tight band that people describe around their head. The duration of these headaches can be anywhere from hours to days or even weeks. A lot of my patients tell me that they essentially feel they have a headache every day. It's just it goes up and down and it's on and off. Now, the treatment for these headaches, whether we're calling them tension headaches or we're calling them cervicogenic headaches, is different from migraine treatments. They tend to be less severe than migraines, and the mild ones will respond to over-the-counter medications like Tylenol and ibuprofen or other NSAIDs. However, sometimes a nerve medication can be added, such as gabapentin or Lyrica, and muscle relaxants can sometimes help loosen up the muscles of the head and neck too. Some practitioners like to use amitriptyline and other tricyclic antidepressants for the tension headaches that are more similar to the migraines. From a procedural standpoint, occipital nerve blocks are an excellent strategy for these headaches, because basically you would be decreasing the inflammation around the occipital nerve that is the root cause of these headaches. More severe cases of cervicogenic headaches can be due to facet arthritis in the cervical spine, and those would require more involved procedures like cervical medial branch blocks and radiofrequency ablation in the cervical spine. But then when it gets to that point, I wouldn't really call them primary headaches anymore. Okay, so now the third major category of primary headaches is what we call trigeminal autonomic cephalalgias, TACs. And the most common example of that is cluster headaches, but I'll be touching on the other subcategories too. What is special about this family of headache disorders is that they all have autonomic features. So what does that mean? These headaches are usually centered on one eye. Then they involve runny nose, watery eye, red eye, droopy eyelid. So these are what we call autonomic features because they are due to a specific part of the nervous system called the autonomic nervous system. Now, the important thing also about these headaches is that they tend to be unilateral. So they only affect one side of the head. Now, it could alternate between the right and the left, but it tends not to be both at the same time. They are usually much shorter in duration. So for cluster headaches, they are only between 15 minutes and 3 hours in duration. However, the pain associated with them is extremely severe. So it tends to be a very sharp stabbing pain, again, centered on the eye itself and associated with those autonomic symptoms. Now, depending on the specific disorder within that umbrella of headache disorders, there's going to be differences. So, for example, cluster headaches, which are probably the better known member of this family, are more common in men. Risk factors for it include smoking and alcohol. So alcohol tends to trigger cluster headaches in addition to the other TACs. And they tend to happen in clusters. So you might have, let's say, a few months where you're waking up with these headaches every single night, but then you might go through months or years where you have no pain. And then it's going to come back. That's why they're called cluster headaches. And just like cluster headaches are more common in men, the other members of this family, such as paroxysmal hemicrania, hemicrania continua, and Sankt and Suna, which are acronyms, but I'm not going to say the whole name, those are either equally common between men and women or more common in women. Now, how do we treat those? So the treatment for cluster headaches involves a rescue medication like a triptan. So similar to the sumatriptan that we used in migraines before, but in this case, it tends to be more intranasal or subcutaneous for faster delivery, because obviously these are very abrupt and quick onset, very severe headaches. So we don't have time to wait for the oral medication to kick in. Classically, they are treated with oxygen, so like a mask with oxygen therapy, but that's inconvenient for a lot of patients. And these days, we tend to treat them more with medications and not oxygen. And for preventative treatment, we tend to use verapamil, which is a calcium channel blocker, as first-line medication for cluster headaches. One procedure that is very effective for cluster headaches is actually occipital nerve blocks, which I have a separate video on because occipital nerve blocks are very useful for all of these primary headache disorders, whether it's migraine or the cervicogenic headaches or the cluster headaches. All right, now the other members of the TAC family are what we call indomethacin responsive headaches. Indomethacin is an NSAID, a very specific type of NSAID that seems to be the only one to work for these kind of headaches. And so we use indomethacin actually as part of the diagnostic criteria for some of these headache disorders.